Hello, everyone. My name is Ilana Reinhold. I'm an ID physician researcher at the University Hospital of Cologne, and it is my great pleasure today to present you the section on ocular candidiasis as of the Global Guideline for Diagnosis and Management of Candidiasis, which was a huge initiative by the ECMM in cooperation with ISHM and ASM, led by Oliver Cornely, Rosanne Sprute, and over 100 co-authors. So let's start first with a case presentation. So we have a 24-year-old man with an acute myeloid leukemia, and he presented himself with a vision loss of both eyes and was diagnosed with a Candida endophthalmitis. And you can see here at the right side, he has multiple premacular vitreous purse ring-shaped condensations, and on the left side, very impressive subretinal abscess where surgery was considered. And the patient was back then treated with caspofungin for 10 weeks. And we can see here below that at 10 weeks of treatment, at the left side, we have vitreous condensations. And on the left side, we have very severe macular scarring. And the patient still had a vision loss diminished by 80% in both eyes after 10 months after treatment was finished. So now let's go first into what is ocular candidiasis. So we have two different structures in ocular candidiasis, which is the endophthalmitis and chorioretinitis. And one of the main reasons why we want to see if patients have chorioretinitis is because it can progress into endophthalmitis, which can lead to a vision loss. So endophthalmitis is in retrospective studies described as low as 0.6 to 2.8%, and chorioretinitis has a very broad frequency of 2% to 20%. And we will have a look at why this frequency is so broad. The visual symptoms, which can be blurred vision, photophobia, or also a vision loss, are reported in only 20 to 30% of conscious patients with ocular candidiasis. And this is due to the fact that the macula has also to be involved to report visual symptoms. So if we have a look at the studies which entered the guidelines for the recommendation for fundoscopy, you can see that these are mainly strength of evidence, quality of evidence of type 3, and strength of recommendation is B for a fundoscopy. And what is also important to understand, these are mainly retrospective data, and not in all patients routine fundoscopy was performed. For example, we have here the study of Sun of 2019. Here only 60% of patients had routinely performed fundoscopy, which of course leads also to different rates of ocular candidiasis. And in the study of 2017 from Antonio Vegna, which prospectively looked at candidemia but retrospectively analyzed the performance of fundoscopy, saw that only 46% had the performance of a fundoscopy. And risk factors which were recurrently described but with no significant association in all different studies were Candida albicans species, which are more frequently associated with ocular candidiasis. Also the CVC, which was not removed, high beta D glucan values, and also immunocompromised patients were at a higher risk to develop ocular candidiasis. And this goes on also in the other tables. So we have mainly retrospective data, and there is a lack of routine screening. So we don't know the real rate of ocular candidiasis. And most importantly, there is also a risk of unspecific ocular findings. And these can lead to unnecessary adaptations of antifungal treatments, and especially a switch from echinocandins to azoles, while the ocular candidiasis not has to be due to the candidemia itself, but can also be due to hypertension or also hypercholesterolemia. There is, however, one big exception to all these studies, and this is a study published in 2011 by Astrid Ude-Lashoff in CID, and this is the only prospective study looking at, in a systematic way, performing fundoscopy. So the study itself included 370 non-neutropenic patients, and it was an RCT with a 2-to-1 randomization to voriconazole or amphotericin B, which was followed by a treatment with fluconazole after 3 to 7 days. And they performed a fundoscopy at baseline, at day 7, at 2 weeks, and also at 6 weeks after end of treatment, and they've indicated at 12 weeks of end of treatment. And hereby they found that there were 16% of ocular abnormalities, but out of the 60 patients in the 370 patients, there were 20 patients which had a possible ocular candidiasis, so not, which can also be not be due to the fact of a candidemia, but also associated to other retinopathies. And they found that 1.6% of patients had an endophthalmitis, and all these patients did not need any treatment by vitrectomy, and they also saw an association which was significant for longer duration of candidemia associated with ocular candidiasis, where the cutoff was made at 4 days of treatment, and they also saw a significant risk for Candida albicans candidemia with ocular candidiasis. And this has also been seen in mouse model, which shown that Candida albicans has a higher virulence for ocular candidiasis than other Candida species. So what is now entering the guidelines? So as there is a lack of a definitive outcome or cost-benefit data for the practice, a routine screening of every patient with candidemia cannot really be endorsed. But erring on the side of a cautious approach, the guideline still says that we should screen all patients with candidemia, so it is strongly recommended. And at the present, we don't have a really a risk stratification present to foresee which patient can develop ocular candidiasis and which not. So, however, we know that there are resource-limited settings all over in every center present. So if the capacity for fundoscopic exam is not available, the guideline recommends the very least to perform a fundoscopy in the following patients. So these are those with ocular symptoms or signs, patients who cannot verbalize their complaints, immunocompromised patients, and patients with prolonged candidemia, so where the cutoff was made for 48 hours. And what about timing? So based on this retrospective data is that the timing would be most optimum for 1 week after the onset of candidemia or after neutrophils are recovered in neutropenic patients, and this is an unproven approach. So now let's move on to the treatment of ocular candidiasis. So here we have 2 different pathways. We have at the left the endophthalmitis and at the right the chorioretinitis or retinitis, which can be either asymptomatic or localized. So if there is no macular involvement, you stay at this right path and refer to candidemia management by giving an echinocandin, which is a very good penetration also into retinal structures and also into the choroid. However, if you have an endophthalmitis, most studies are based on fluconazole treatment because it has a really excellent penetration not only in the retina and the choroid, but also in the vitreous fluid. But if you have a Candida species, for example, Candida glabrata, with very high MICs for fluconazole, you can also consider to give voriconazole treatment. And if altogether you have a Candida species with azole resistance, you can also consider to give liposomal amphotericin B. And to give intravitreal antifungal treatment, this is as always to be discussed as a case-by-case discussion with ophthalmologists, as also the early vitrectomy to prevent severe macular scarring. If you have no liposomal amphotericin B available, do not just switch to deoxycholate amphotericin B, since this has a very limited penetration into the vitreous fluid, but prefer azole treatment together with also localized treatment. So here you can find all studies which entered these treatment recommendations. So you can see also here we have very low quality of evidence, but very high strength of recommendation. This is mainly due to the pharmacological properties of fluconazole. And here again, we have also transferred evidence from this randomized controlled trial I presented you earlier, where all patients were treated with voriconazole or amphotericin followed by fluconazole. And in this patient, no vitrectomy was performed at all, and no patient had any visual loss in the long-term treatment. So now let's go back to 2007. So what would have been done probably other than in 2007? In 2025, treatment with caspofungin would have been probably fluconazole or voriconazole. Probably also there would have been a discussion for vitrectomy and also the treatment with localized intravitreal antifungal treatment. And with that, I would like to thank you for your attention and thank all co-authors again for this huge literature review. And if you have any questions, you can always reach out. Thank you very much.